I'm Stan Darazinski. I'm a clinical professor of medicine at Stanford and medical director of the Antimicrobial Stewardship Program, focusing on antimicrobial safety and sustainability. Empiric antibiotic therapy is administered in order to provide initial control of presumed infections of unknown cause at a time when, in most instances, we do not know the etiology of the infection or even whether an infection is actually present. If we are subsequently able to identify a pathogen, we can then shift to definitive therapy, adjusting the antibiotics to provide optimal treatment of the patient. The initial choice of antibiotic therapy is critical to a favorable outcome. On the other hand, we also know that inappropriate therapy, as well as overly prolonged therapy, adversely affects the individual patient and the bacterial ecology by unnecessarily exerting a selective pressure leading to emergent bacterial resistance. Thus, while the empiric initiation of broad-spectrum antimicrobial therapy in patients with sepsis is generally recommended, it is critical that the clinician repeatedly reevaluate that therapy. As clinical and laboratory data become available, therapy should be appropriately adjusted. The process of this reevaluation has been called an antibiotic timeout. The Centers for Disease Control and Prevention recommends this process occur 48 hours after antibiotics are initiated, and that it consists of 4 basic steps. First, a review of the available clinical and laboratory data, especially the microbiological results. Second, a determination of the likelihood that the patient has an infection that is likely to be effectively treated with antibiotics. At this time, there should also be a reevaluation of dosing and route of administration. Third, determination of the necessary duration of therapy. And fourth, documentation of these elements of care. The CDC is not alone in recommending this as a standard process of care. The 2012 Surviving Sepsis Campaign guidelines also recommend antibiotic timeouts, stating that the patient should be monitored and the antimicrobial regimen should be reassessed daily for a potential of de-escalation to prevent the development of resistance, reduce toxicity, and to reduce cost. Finally, the Centers for Medicare and Medicaid, in their finalized worksheet published in November 2014, recommend that there be a formal procedure for all practitioners to review 48 hours after the initial order the appropriateness of any antibiotics prescribed. Among the principles to consider during this antibiotic timeout are to treat infection, not colonization or contamination, and to target any identified pathogen as narrowly as possible. Any bug-drug mismatch should be resolved. Redundant coverage should be eliminated and dosing optimized. In some cases, a conversion from intravenous to oral antibiotic administration should be considered. If no pathogen is identified and the patient is clinically improving, consideration should be given to the possibility that the patient does not, in fact, have a bacterial infection, a determination that might constitute a reason for antibiotic discontinuation. The most difficult circumstance occurs when microbiological studies are negative and the patient is clinically deteriorated. In such cases, a search for sources of infection, such as an abscess requiring drainage, that may be dealt with directly should be considered. Now, please examine the following cases that illustrate the antibiotic timeout, a critical element in achieving the best possible outcomes for our patients.